Oncology has to be considered, and Dr. Yogesh Panchwag is synonymous with Orthopedic Oncology in Pune. In the last 2 decades, a lot of corporate hospitals have come up. So those who want to remain in the metros, that is a definite consideration. Dr. Abhijit Agashi will be speaking on the same. Then comes academic institutions, where most of us already are and some would be. So that's why Dr. Sanjay Dev of D.Y. Patil University. Then comes government jobs. Though they were not so preferred till recently, I would say that it is going to stage a big comeback. And last but not the least, we have got our own Dr. Yash Shah speaking on how to set up an orthopedic hospital. Now I invite our Executive Director, Dr. Suchitra Nagri, Madam, to give her introductory remarks. Over to you, Madam.
Thank you, Dr. Kamath. Once again, I welcome all the orthopedic surgeons of Pune city and different places. Today is the third session organized by the Department of Orthopedics, wherein we are just trying to give a glimpse of what are the opportunities and the avenues available by specialty in the field of orthopedic. So on behalf of Mymar Medical College, I welcome Dr. Yogesh and Dr. Abhijit and Dr. Sanjay Dev, sir. I think Dr. Mahendra will be joining a little late as per the updates from the office. So I welcome all of you. Hello, Yogesh. I hope you remember that. Namaskar. The connect with orthopedic field from my side is my husband is also orthopedic surgeon. And when Yogesh was studying in Sancheti, my husband was also doing diploma in Sancheti. And it was the first conference in Ahmedabad. I still remember we all attended along with all the residents of Sancheti Hospital. That apart, I think orthopedic is really a field wherein there are so many super specialties are coming up. Earlier days, I still remember that there were people with basic orthopedics and then joints came up. But now I think tumor specialties and onco and plastic and hand specialist surgeons and foot specialists and whatnot is coming up. So I'm very sure that this webinar, which is conducted by Department of Orthopedics of Mymar Medical College, will definitely help all these students who are attending this to choose the pathway, the right pathway for their fields. And as we are covering, starting from the basic orthopedics to the opportunities world over, I'm pretty sure that people will take this opportunity to learn and to choose the right pathway for themselves. Once again, I welcome all of you and thank you very much.
Thank you very much, Madam, for your encouraging remarks. And now it's over to Dr. Srirang for setting the ball rolling.
Very good afternoon to all. So at the start of today's session, the first session will be by Dr. Yogesh Panchwag about orthopedic oncology. So I would like to introduce Dr. Yogesh Panchwag. He is one of the eminent orthopedic oncologists practicing in Pune. He has been practicing since 2 decades almost in the Dinanath Mangeshkar Hospital as well as Sancheti Hospital. He is a fellow of the Tata Memorial Hospital, Mumbai, also of the Rizzoli Institute in Bologna, as well as foreign fellowships of Birmingham, UK. He is PG teacher for both MS as well as DORTH examinations and is the founding member and trustee of the Indian Musculoskeletal Oncology Society. He is the member and Asia Pacific representative of the Psychot Tumor Committee as well as member of prestigious committees as the ISOLs as well as editors of the journals like Journal of Bone and Soft Tissue Tumors. He is in charge of the bone bank at the Dinanath Mangeshkar Hospital and we are indeed lucky to have sir today with us on our panel. Thank you, sir, for joining us. I'd like to allow them, sir, to continue his lecture.
Thank you very much, Dr. Srirang. A very good afternoon to all of you, to all listeners. And indeed, I must say, a very unique kind of a concept by the Department of Orthopedics in Myanmar and Myanmar Institute in general. I have talked to a lot of people earlier about this particular topic, about this particular specialty, but this is at an institutional level. Probably I would say that this is the first such experience that on a larger scale. I'm going to share in short my story as well as the story of this particular field, which I would say amongst all the super specialties in orthopedics is probably one of the youngest ones. There were very few orthopedic oncosurgeons in India who started practicing orthopedic oncosurgery as a specialty. And that was as late as in the late 90s. And then slowly more and more people have joined in, and now we are a considerably bigger group. A very good layout of the sessions has been again laid down by Myanmar and the Department of Orthopedics in Myanmar. So I'm going to be sort of talking to you under the various headings that they have suggested. So in short, to begin with, my journey so far after my MBBS in Pune, I did my MS in Pune as well. As Chitra Madam was saying, I am an alumnus of the Sancheti Institute. Finished my training in 2002, passed my DNB in 2003, and thereafter worked in the municipal corporation hospitals in Mumbai for a year. After that, I was a fellow in the bone and soft tissue unit at Tata Memorial Hospital in Mumbai for 2 years. Completed my diploma in tissue banking from National University Hospital in Singapore, which was an correspondent course, you may call. You had to go there twice to finish the course. In 2005, after I finished my training at Tata Memorial Hospital in Mumbai, I went to Birmingham in UK to the Royal Orthopaedic Hospital as a visiting fellow. And in 2007, I was awarded the Marie Curie Fellowship in the Rizzoli Institute of Orthopedics in Bologna, in their bone and soft tissue unit, where I spent a short while again. For the last 15 years, from the end of 2005 till date, I am practicing as an orthopedic oncosurgeon in Pune. I am involved in a bit of teaching as well at various institutes. I am mainly attached at Dinanath Mangeshkar Hospital and Sancheti Institute, but I do occasionally get the opportunity to teach and work at some other prestigious institutes in and around the city of Pune. As Shrirang had mentioned earlier, that a few of us are practicing orthopedic oncosurgeons within India started the Indian Musculoskeletal Oncology Society in 2015, of which I am the current secretary. And we also started a journal named as Journal of Bone and Soft Tissue Tumors, again with association with the Indian Orthopedic Research Group, which has been running successfully for the last 5 years. And there has been a considerable amount of material that has been printed in that journal for the PG students and for the early practicing surgeons as well. Last year, I've had the opportunity to become the Asia Pacific representative of the CCOT Tumors Committee, where again we are trying to sort of see whether in which way we can sort of increase the popularity of this particular field and increase the awareness of the branch. Well, the reason why I chose orthopedic oncology was actually twofold. One was an academic reason, and secondly, you can say was not really a financial reason, but a non-academic reason. The academic reason being, when I was a resident, there was hardly any exposure to proper management of primary malignant bone tumor. We hardly used to get to see primary bone tumor cases because we were not known as a referral center for tumors in those particular days. And most of the patients used to be, referred to a tertiary care center like the Tata Memorial Hospital in Mumbai. So I sort of wanted to learn a little bit, had seen a few cases, wasn't really aware of how, good way they are supposed to be managed. So there was a little bit of an academic sort of an longing to go and learn about the basics of treatment and then the advanced treatments of these particular lesions. This was muted just a minute. Yeah, the second reason why I chose this particular field was that I knew that I was going to be practicing in an urban setting, And I wanted a niche field to practice where there was, there was a bit of a challenge, as well as I wouldn't have to sort of focus a lot on promoting that particular field. But this particular sort of turned out to be a counterproductive step, as you will come to know from my further slides. I did try initially in my practice to combine the trauma practice with specialty onco practice, but I soon realized within a short span of 3 to 6 months that that's not going to work. And if I have to develop an oncology practice, then I'll have to be dedicated to orthopedic oncology. And ever since then, I have been practicing orthopedic oncology only in my setting, in my practice. At that particular time, I had decided to give myself about 7 years time and then reevaluate. And I've gone through a lot of period. As you can understand, in the beginning, 5 to 7 years, there was a lot of struggle. You had to spend a lot of time to prove yourself, to bring in new concepts, to allow your colleagues some time to sort of accept those concepts and lay their trust in you, and then start referring cases to you. So that's something that that takes a bit of a time. Special qualities required for this field are nothing different than the general other specialty orthopedic fields require. And the most and foremost important quality that one needs to have is a very good liking to this particular field, because there is a bit of a struggle in this particular super specialty to begin with, especially if you're going to start practicing on a private scale. And if you don't have the liking, then that particular struggle probably doesn't become very enjoyable. Obviously, you need dedication to the field. You need a lot of consistency, because you have to keep on doing the same things again and again and keep on proving yourself. And obviously, because there's a long wait, you need a lot of patience and perseverance, because the gestation period is going to be very, very long compared to the other super specialties. The scope is actually manifold. There are a lot of gray areas in this particular field. We are involved in the treatment, surgical treatment of benign and malignant bone tumors. We are also involved in the soft tissue tumors, which arise primarily in the bone and connective tissue, or which are metastatic lesions. So we get the opportunity of treating all the types of lesions, neoplastic or tumor-like lesions in the long bones and the axial skeleton. And mostly, I'm not saying that this is a strict rule, but mostly this type of a practice is based out of an institutional setting. It's very, very difficult to have a small private setup of this sort of a thing, but it is not completely impossible. So that was the scope. What are the challenges in this particular field? The biggest challenge is the low incidence and prevalence of bone and soft tissue tumors. So if I have to give you the numbers, only 1 to 2% of the malignancies that occur in a human body are in the musculoskeletal. Sarcoma, which is the commonest primary bony malignancies, what are the number of cases per year? It is as low as 3 to 4 per million population per year. So the numbers are really, really very small. And then there are a lot of gray areas. The soft tissue tumors are typically being treated by general surgeons as well. There are oncosurgeons from the surgical oncology side who would want to treat the soft tissue tumors. The neurosurgeons would want to treat the metastatic vertebral lesions, where the vertebral regions are most common. Plus, if there are any pathological fractures, then obviously our trauma colleagues would want to treat them. Most of them will be confident enough to handle those particular cases. Sometimes the nuances are missed, but they feel that they are competent enough to handle those particular cases. So there are a lot of gray areas. Obviously, this takes the waiting period on a very long scale. Most of this practice of orthopedic oncosurgery is a referral practice. So basically, the patient is going to be seen by a general orthopedic surgeon somewhere, and then he's going to be directed towards you. The patient and the patient's family, it's very difficult for them to know your name directly unless and until they say Google you or search the internet. Most of our patients are not that sort of aware or inclined, and hence most of the practice is still a referral based practice. The other difficult perspective is the socioeconomics. Most of our surgeries now are limb salvage surgeries, even in primary bone sarcomas. So basically, even if there is a malignancy in the limb, either the upper or the lower, we typically treat them by doing limb salvage surgeries in a specific fashion that does not affect the overall outcome. Hence, this becomes a bit costlier perspective issue when we are talking about treating them with chemotherapy and radiation and maybe a megaprosthetic reconstruction. And sometimes the patients may find it a little difficult from socioeconomic perspective. You have to have some sort of an methodology or some departments taking care of this particular. Another problem or another challenge of this particular field is the outcomes. You know, in fracture, in trauma, you know that if you do a job well, if you follow all the principles, you are going to have a fantastic outcome. This is not so in primary bone and soft tissue sarcomas. Even if you give your best, even if the family gives their best, the outcome are roughly around 50 to 60% only, because 40 to 50% of our patients are going to have metastasis and they're going to be dying because of the disease within the next 5 years' time. So this is something that you have to accept psychologically, mentally, when you start practicing in this particular field, and see to it that this is not affecting your interest, or this is what you have to be very clear about in your mind, that it is also the biological aggressiveness of the disease that is going to decide the final outcome for the patient. So it's not just your skills, your understanding, the way you put your principles into practice, but it is also the biological aggressiveness of the disease that is going to decide what's going to happen with your patient. Even in those patients who go on to have a complete cure, and which we declare at the end of, say, 8 to 10 years of follow-up, and we have about 50 to 60% of those type of patients, they may have some issues with their functionality of the limbs, and you may be, you should be willing to deal with those particular aspects at a later date as well. So one particular patient is going to probably undergo multiple types of surgical procedures, some by you, some by your colleagues. So you have to understand that well and sort of prime yourself and prime the patient and the family as well, right from the day one. How do we reach where we want to reach in the field of orthopedic oncosurgery? So first and foremost, we have to train appropriately and adequately. Orthopedic oncosurgery is a branch where the principles are actually sometimes diametrically opposite the principles of a fracture fixation. So there's a lot of stress on biological fixation in fracture treatments, whereas in tumors, we typically depend upon the non-biological reconstruction options more often. We don't go through the internervous planes, so our approaches are a little different. Surgical approaches are a little different. So basically, you have to have a different type of a perspective, different type of an exposure. You have to unlearn a few things and learn a few things more. There are a lot of exotic reconstructions that we do, and sometimes it is very easy for a student to get enamored by the type of reconstruction, by the type of functional outcomes the patients get. But the type of responsibility that you carry for the patient is also huge, and if you have to work independently in this particular field, you have to be aware of those responsibilities as well. In practice, you could be working either in a government setup or a private setup, or sometimes the setups are a mix of public-private kind of a partnership, and depending upon what type of a setup you work in, the things could be a bit different. We have to remember that to begin with, at least, we need to choose cases well. We have to focus on treating the straightforward cases and then go on to treat the complicated cases later on. In orthopedic oncology, it is always a team approach. I am not the only person who is going to be treating the patient alone. There's my radiologist, there's a pathology team, there is a radiation oncology, medical oncology team involved, and we do something what we call as a tumor board discussion or a multidisciplinary team meetings, wherein the patient's final management is going to be decided. So one needs to be building such a team over the years if you have to be successful in orthopedic oncology. Most importantly, we have to know when not to operate. We have to let go some patients. We have to treat them with palliative intention if they are presenting very late. Okay. Your colleagues, those who are going to refer cases to you, have to know your intention, your availability, your results for them to lay their trust in you. So you have to understand what's going to be your responsibility and what is not your responsibility. The aggressiveness of the disease is not your responsibility. The genetic aberration that has led to that particular tumor formation is not your responsibility. But yes, I mean, if you have to treat a particular patient properly, you have to know that it is your responsibility, that you are aware of that particular technique and you are well versed with that technique. Also, you have to know what all complications can occur, because orthopedic oncology is one such field where the complication rate is probably the highest amongst the different fields of orthopedics. I might be having the highest rate of complications amongst all the faculty members that you got to hear over the next, or you will be hearing in the next sessions as well. So one needs to be very well versed in handling the complications as well. So you can't shun away the patient. You have to take responsibility for whatever complications occur. It might not be your fault, but you have to counsel the patient beforehand that such and such complication may occur, and you have to be confident enough to be able to treat that particular complications. There are no shortcuts to the top. I don't believe that I am at the top right now. I am still learning. You still keep on learning in these particular branches all the time. Well, I might be just a few steps ahead of my junior colleagues, but I'm definitely in the top. But what I have realized and what I can tell you is that there is no need of taking any shortcut. You can follow all the principles, disease-wise or otherwise, and still may be able to make a good mark for yourself and for the branch. What are the steps of qualifications? Well, there are only about 2 or 3 centers within India which run certified courses in orthopedic oncology. One is the Homi Bhabha University 2 years diploma course in orthopedic oncology, which is run by the Tata Memorial Hospital. It's a 2 years course. There is a proper entrance exam. There is a thesis that is allotted to a student, and then there is an exit examination. The student has to be at least 1 year post-MS for being eligible for this particular entrance test. And the second institute that does this is the All India Institute of Medical Sciences in New Delhi, which have a 2-year fellowship program. And they need a 2-year post-PG experience. Again, they have an entrance test and selection process and exit exam as well. There are other private institutes which run fellowship courses, though they may not be certified. Of them, some are the Hinduja Hospital in Mumbai, Rajiv Gandhi Cancer Institute in Delhi, and the Max Institutes again in Delhi, Gujarat Cancer Research Institute in Ahmedabad, HCG in Bengaluru, and I believe CMC, Vellore, and Adyar Institutes are also reputed cancer institutes within India, but I'm not very sure about whether they run a certified orthopedic oncology fellowship course or not. There are a lot of good orthopedic oncology centers abroad, and some of them, a couple of them where I have trained in, some of them I have visited. These are Royal Orthopaedic Hospital in Birmingham, UK, and the Royal National Orthopaedic Hospital in Stanmore, UK, one of the 2 premier institutes in the United Kingdom. In Europe, there are good centers in Italy, in Bologna, it's Rizzoli Institute of Orthopedics. There are good centers in Milan and Florence as well. Good centers in Münster, Germany. In the US, the Mayo Clinic, the Memorial Sloan Kettering Cancer Center in New York. In Canada, there's Mount Sinai Hospital in Toronto. And if someone's thinking about Australia, and then there's St. Vincent's Hospital in Melbourne, which have very good curriculum and very good courses which undertake fellowships in orthopedic oncology. What is the initial investment required for a field as such? Well, it's only time that you need to get. The other set of requirements are pretty much the same as the other orthopedics. So you don't really require anything different than what's required by your trauma colleague or by your replacement colleague. Most of the things that we need to have in our orthopedic operation theater are sufficient enough for you to do the reconstructions in bone and soft tissue tumors. Is there any difference in practicing in the tier 1 cities versus tier 2 or tier 3 cities? Yes, because as I said in the beginning, that this particular branch has a disadvantage of low volume of work to begin with. So you need to have a good drainage area. So one needs to see to it that you are practicing in a place where there is a good flow of patients, where there is a good sort of facility for working these up, good pathologist who's going to be a part of your team to be who's going to be reporting on these particular biopsies that you're going to do. So these are the things that you need to take care of and what's the time required to settle down in your own practice? Well, if it's a public setup, it's a government setup, then for people to really start knowing your name, it takes at least around 5 years of time. But if you're going to be on a private setup in maybe a tier 1 or at the most a tier 2 city, then I would say that you're looking at least something more than 8 to 10 years of time that you need to invest before you can really start getting recognized as an orthopedic oncosurgeon. Obviously, and there are about 20 to 25 orthopedic oncosurgeons within India now who are dedicatedly practicing only orthopedic oncosurgery. So we are there to guide you. Feel free to get in touch with us through IMSOS, also through the Indian Musculoskeletal Oncology Society. We will be able to guide you and channelize our resources so as to help you in the best possible way. So thank you for inviting me. Thank you for listening me out, and all the best to you all. Thanks a lot.
Thank you, sir, for the interesting lecture. If any participants have any questions, they can ask sir right now or type them in the chat so that we might see them.
Good afternoon, sir. Hello. Good afternoon, sir. Sir, you mentioned about fellowship in oncology in foreign universities. But how to get in there, sir? Can you please elaborate?
So basically, you will have to go on to their websites. Most of these particular fellowships are taken up in advance by about at least a couple of years. So I would advise that initially work in an Indian setup, especially in India. If that's your long-term goal, then you need to have worked in some Indian setup, and then keep on applying to these particular institutes outside where fellowships are actually decided 2 years in advance.
Yes, sir. Thank you, sir. There is one question in the chat, sir. Requesting you to advise whether to take up fellowships immediately after passing or to practice general ortho for a year or two before taking up this field.
Yeah, I would actually say that you need to be practicing a bit of general orthopedics, trauma, as well as core orthopedics for at least a year or two. And most of the institutes within India also will actually want you to have completed 1 or 2 years of general orthopedic exposure, because when you are learning, it's a different thing. When you are passed out, then there is a different sort of a learning. So I would say that yes, spend a little bit of a time in trauma, spend a little bit of time maybe in a broad specialty of your liking, and then start taking up fellowships. Don't go for dedicated fellowships, specialty fellowships immediately after your exam, because the learning process during your tenure as a student is different. And when you start doing cases on your own, that particular learning process through practical experience is totally different. So I would advise you to spend a little bit of a time, at least 2 years or so, practicing general orthopedics.
Yes, sir. Sir, there is one more question.
Yeah.
One of our faculty, sir.
Yes.
Thanks very much for your address, sir. Really appreciate that.
Thank you, sir.
I'm not sure whether you are able to hear me or not.
I'm able to hear you. I'm not able to see you.
So, that's okay. So, I'm a practicing orthopedic surgeon here in Myanmar.
Okay.
So, if I want to get 1 or 2 months of observership just to get the hands on and see how the things run in the oncology theater.
Right.
Are there any institutes in India which can entertain me?
Yes, obviously. There are institutes, the Tata Memorial Hospital will take you in as an observer. You don't have to give any exam of any sort for that. They charge a very nominal fee for an observer on a monthly basis. So yes, that kind of a facility is also available. When you want to spend a very little time, say as short as 1 month or 2 months, because you are short of time, then I would suggest that you go to a high volume center instead of a moderate volume center. Otherwise, such observerships, they are available at our institutes also, and they are at no cost. So typically, we don't charge anyone for just being an observer. But in a moderate volume center, the type of cases that you will get to see will be spread over, say, 3 months to 6 months time, all those type of cases. The same type of cases, maybe in a high volume center, you will be able to see in 1 to 2 months time. So if you want to just go as an observer, yes, that's possible. Just choose a center of where the work is of high volume. So you will get to see a plethora of cases of different types over the spectrum in a short duration of time. Just to give you an idea about how things are and how things are handled.
Thank you for the interesting talk, sir. You have indeed shed light on this subspecialty of orthopedics, which is shrouded in mystery. I would like to thank sir as always at the forefront in guiding young PG students as well as young orthopedicians. And it is not everybody's piece of cake to practice orthopedic oncology. As sir has rightly said, that it needs a lot of dedication as well as time and consistency. The challenges in the outcome as well as there are no shortcuts to the top is some advice that sir has given. And it has given us a wonderful insight in the field and has inspired many of us to take this up again. I'd like to thank sir for his wonderful lecture. We'll move on to our next session. The next session is by eminent orthoplasty surgeon Dr. Abhijit Agashe. He is going to speak on the nuances of orthopedic practice as well as that of corporate orthopedics in current scenario. I would like to introduce Dr. Abhijit Agashe. He is a consultant orthoplasty surgeon at Sahyadri Hospital, Pune. He has completed his MS in 2004 from Sancheti Hospital, and afterwards he has completed international fellowships in South Korea and then at Germany. He has also completed fellowships for sports medicine and has done the AO fellowship at Germany. After completing his training, he has worked at Sion Hospital and YCM Hospital. He has since then started his practice in 2006 at Sahyadri Hospital as a joint replacement surgeon and is since associated with them. I'd like to hand over the mic to sir for the next session. Thank you, sir.
Thank you for inviting me. Is my screen visible now?
Yes, sir, your screen is visible.
So I'd like to thank Myanmar Institute for inviting me on this talk on establishing as an orthoplasty surgeon and in a corporate setup. I'd like to say hi to Yogesh as a good friend of mine, seeing him after a very long time, particularly because of this corona. And also I have to thank Dr. Mahesh Gauri for giving or asking me to share my thoughts here. This is more of an informal, non-academic talk where I think majority of the participants are just pass out MS orthopedics and they wish to further lateralize into their different specialties.
Dr. Abhijit, sorry to interrupt you. The audio quality is not good. We are not able to get a clear line.
Can you hear now?
Yeah, this is much better.
Yeah. So the audience today is probably just passed orthopedic surgeons who wish to lateralize into and for them it's a general talk, nothing to do with arthroplasty, but it's a basic general talk about how to go ahead in your private practice before you actually start and how to get things done. So when you say you wish to establish as an arthroplasty surgeon, the first thing, as Yogesh has also pointed out, is majority of the times, majority of orthopedic training institutes are mainly traumatology training institutes where the focus of training is on trauma. So majority of the orthopedic surgeons who pass out from teaching college are good in trauma or are trained in trauma. For that, a person who wishes to divert to an arthroplasty field first need to work with a specialist orthoplasty surgeon. If possible, do accredited fellowships, then do a hands-on work for arthroplasty, and then lastly, start your own private practice, which I do years before you actually start practice in joint replacement surgeries. So, what do you mean by working with a senior? After you have completed your MS, I would probably ask every one of you to go to a general hospital and do general trauma first, get hands-on work and hang off doing general trauma, because that is the backbone of any orthopedic surgery. Before you venture into any specialty orthopedic practice, either it be maybe joint replacements or arthroscopy or even onco-orthopedics. So first, after you pass out, you better go to a general orthopedic setup where you learn on hands-on practice for trauma patients. And once you have done that, you need to then go further into the field of arthroplasty. Then you need to choose a person with whom, a senior person with whom you need to learn orthopedic or arthroplasty. What do you need to choose is you have to choose a person who has good volume. Now, how do you define good volume? If you are a keen observer and if your teacher is open to teaching and give you the right ideas, even around 10 to 15 cases a month would be a good volume for you to learn. The person you are going to learn has to be academically as well as clinically oriented so that he is well versed with the latest techniques and the latest equipments that are needed. What is the time frame before you actually go in for the next part of your training is, I think, is minimum 6 months, preferably a year, before you go ahead for some fellowships. Now, once you are done your training, you further start searching for fellowships. There are two types of fellowships here. The first one is an inland fellowship or a domestic fellowship, and the second is a foreign fellowship. The inland fellowship could be the same that you probably are going to learn from your senior. So if possible, if you get a senior who will offer you a fellowship of 6 months or a year, and at the same time you will get to learn a lot of techniques or the basic primary things of joint replacement, is easier. So getting an inland fellowship comparatively is much easier. It turns out to be much cheaper because you are going to spend in Indian rupees. Comparatively, the wait time is much lower. Usually, 3 to 6 months after you have applied any of the inland fellowships. In this, I would, particularly in the case of our country, where we are spread out across from Kashmir to Kanyakumari, I would like to tell you one thing very clearly, that preferably to choose a fellowship, a domestic fellowship, in an area where the spoken language is the same as yours. So you are able to get the communication. That communication is not only with the patient, but the communication is very vital when the operating team is talking to each other at the time of surgery. And the small intricacies which you learn in the surgery or during the procedure are important if you are able to speak the same language or you are able to understand what they are talking to each other. Majority of the fellowships inland are paid or they pay you a stipend. The stipend is not very high. You can probably sustain for yourself. But even if you don't get any stipend for an inland fellowship, I think it is absolutely okay if you are getting a good teacher or a good mentor when a good volume of surgeries are happening and the teacher is academically also oriented. Once you have done a Indian fellowship, the next thing is to come is foreign fellowships. Now, the foreign fellowships are really hard to get. The wait time is pretty long. As Yogesh has rightly said, it ranges from not less than a year minimum to almost 3 years. So what I probably will suggest all our junior colleagues is apply for a foreign fellowship at the same time that you are applying for a domestic fellowship, so that your wait time is reduced, and by the time you get a foreign fellowship, your primary Indian fellowship is already done. It is difficult to get clinical or accredited fellowships. Why clinical or accredited fellowships are important? There are two major aspects to it. Once you are an accredited fellow or a clinical fellow, you get to get into the surgical scrubs and actually wash up for a case and assist the surgeon. Second, in majority of the accredited fellowships, you get paid for doing a fellowship, whereas a plain clinical fellowship which is not accredited, you will not be paid. But there are a lot of fellowships which are available, which are not paid, but you don't have to pay much. The stipend that you get if you have an accredited fellowship is pretty good, but I would probably not mind having a non-accredited or a non-stipendary fellowship where I get a good volume of surgeries being seen and to scrub for almost each case. So how to get a fellowship, particularly inland as well as foreign fellowships. I'll just give you a few ideas how I have tried or how I have gone about my fellowships. Is take help from your seniors and teachers. Now, when I say seniors, mind you, I'm not talking about seniors who are 5 or 10 years seniors to you. Those students who have passed out around a year or two, maybe 3 years prior to you, those are the students who are in contact with majority of these fellowships. Might have just done their fellowships also, and their recommendation is an important link to get into a fellowship. So try and take help of your seniors. Second part is read journals, not just the paper, but you also have to see the authors in majority of the journals will give the contacts, particularly emails mentioned onto their papers. So write emails to those authors and seek a fellowship. Get in touch with those who have already done a fellowship, as I already told you. So those who are actually doing a fellowship or have done a fellowship would be in a better position to tell you which are the open positions. What is the average expected time or wait time you can get in, and they can also recommend your name to the mentor there, so you get in a fellowship comparatively easier. Yes, some companies do offer not a fellowship but an observership, which ranges from a few days to maybe a week. That's also not a bad idea, because you get to go there, you get to know people, and once you are known to them, you can probably ask for a fellowship and then get into a regular fellowship. The next part, the way in which I got my fellowship was, I presented a paper in one of the conferences. Now it was a free paper where I did a total knee replacement in a very bad varus around 40 degrees and used a graft and a screw to reconstruct tibia. And I presented that paper in one of the conferences. And after the session was over, I met one of the professor with whom I did my fellowship. And by the time I could go and meet him, he was, I'm sure that majority of the foreign faculties, if you have seen really well in the conferences, they will make sure that they are attending free papers also. So all these people know you by that time, not by your name for sure, but at least by your face. And when you go and meet them, they will probably be in a better position to probably accept you as a fellow or give you the right channels through which you can apply for a fellowship. So get in personal contact with these people, particularly at conferences, present papers, read journals and send emails. Get in touch with your seniors so that they can give you the exact time or the exact area where you are going to get a fellowship. Now, hopefully you have gone ahead of getting a fellowship and you have got a fellowship. So what do you learn at the fellowship? Obviously, you are going to learn the art of surgery and how to do it. That is all okay. But what more important you have to learn during your fellowships is how do they get their bailout situations in difficult times. So supposing they are doing a total knee or a total hip replacement, and while broaching your femur, they get a femoral fracture or a metaphyseal blowout while doing uncemented stem. So how do they get out of that situation? That what is their bailout during these difficult situations is something you have to keep an eye on and keep on asking your master or your mentor. What is the backup plan they have kept ready while doing even a regular primary total knee or total hip? But majority of these people will have their backup plans ready at the time of their primary surgeries. So you need to learn what are the backup plans these people keep. What are the alternate plans that they have kept ready? So if their primary plan fails or if their primary plan doesn't go through, what are the alternative plans that they have kept? The communication is also a very important part that you have to learn from these stalwarts. Majority of the times, if you see really big people in our field, you will understand that it's a teamwork where you form a team, and the next instrument that you are going to need, the assistant, you don't have to tell the assistant to give the next instrument. So it is a way of communication. So you have to train your assistant in the same way. So this communication intraoperatively you have to learn. And again, as I said earlier, if you choose a fellowship in an area where probably English speaking country, the communication that is happening intraoperatively either with the assistant or the scrub nurse, or even to that matter with the person who is assisting you from the company, you can learn a lot from these communications. One thing I'm for sure definitely here to tell you is that if you are getting a foreign fellowship, make sure that you learn their presentation skills as well as writing a paper in index journals. All of these people are pretty good in writing papers in the index journals and presenting at conferences. So these are the points that you have to make sure that you learn not only the surgical techniques, but the other part of your fellowships.
So once suppose you have done your fellowships also, an inland fellowship maybe for a year, and then a 6 months accredited fellowship maybe in the UK or in Korea. You come back, then you got practice. I would advise you to go ahead and do some hands-on work before you are actually there in the open market. Once you have completed your fellowships or your training, what I will probably advise you is to go to a teaching hospital. By a teaching hospital, you will have a senior who is doing joint replacements or any specialty orthopedic work, and you have done your fellowship to guide you and bail you out if you land up in a difficult situation. General hospitals may also be helpful, but there may be a gap between you and a senior orthopedic surgeon who can help you out. Second, particularly in case of arthroplasty, it's a capital intensive job. So general hospitals may not have patients who can probably afford a joint replacement. So a teaching hospital would be a good idea. If you're not able to get into a teaching hospital or a general hospital, I would advise you to start a private practice of your own and start doing cases with keeping your mentor or keeping your senior into loop and letting him know that you are operating. And if there is something that you need to ask or you need to call him, you are there, he's there to give you, guide you or get you out of that particular situation. So after you have done your hard work, after you have done your hands-on, you have got your fellowship, you're trained, now it's time to decide where to settle down in your life. Now, first thing before you actually do it is you have to decide whether you wish to plastic surgeon or to that matter a pure super specialty orthopedic surgeon. Like Yogesh is practicing pure onco-orthology or I am practicing pure arthroplasty. Or you would like to do a combined practice. A combined practice means one specialty of orthopedics combined with trauma. Now, majority of my colleagues or friends whom I know are practicing into combined practice, where they also practice trauma at the same time they also practice either arthroplasty or arthroscopy. Very few of us are into pure specialty orthopedic surgery or pure arthroplasty, or as Yogesh is into pure ortho-oncology. So depending on that, you need to choose the city that you are settling in. A metro city like Mumbai or maybe Kolkata, Delhi, Chennai, Bangalore is going to be a tough ask. A tier 2 city like Pune, Indore or Nagpur would comparatively much easier. And tier 3 cities are much easier to settle down in life. But if you are choosing a tier 3 city, probably the chances that you will be diverting to a pure specialty orthopedic practice is comparatively lesser, and then you will have to choose in combined one specialty orthopedic surgery with trauma. Then let me come to my last topic, working in a corporate setup. So how do you actually define a corporate hospital or a corporate setup? A corporate hospital or a setup is a private hospital meant for profit who are offering either a general or specialty tertiary healthcare center. Usually, these corporate hospitals are tertiary healthcare centers, or they may have secondary healthcare centers also, which is in a hub and spoke type of a model. These hospitals are majority of the times either 100 or 500 or above beds. They are multi-specialties with state-of-art facilities and excellent backup systems. Working in a corporate setup, yes, it is difficult to get an entry, especially because majority of the corporate setups are either going to ask for a minimum qualification, where majority of them will probably ask for a foreign qualification, or an adequate experience of at least 5 to 10 years before you can join in a corporate hospital as a consultant. You may join these hospitals as a full-time job, where you are a salaried employee of the hospital in a particular specialty. At times, you may actually get in as a junior consultant or a lecturer, which is also not bad if you're going to practice in a metro or tier 2 city to get into a good hospital. And then it's a steep ladder to climb, where you gradually from junior consultant reach to a full-fledged consultant in maybe around 5 to 10 years time. But you have to be on your toes always to get into that particular slot. So what are the advantages of a corporate hospital? The non-surgical part is very easily available and the help is very easily available. The setups are excellent. You don't have any hassles of
medical establishments and management, like whether the mama she has come or help has come, whether some equipment is functioning or it is not functioning. Then other parts, like if the patient is having diabetes or other medical issues, it is very difficult for a small setup to manage all these things together. Whereas in a corporate hospital or in a bigger multi-specialty hospital, it's a teamwork where your physicians will be with you throughout this case and will help you out into these difficult situations, which probably are not your part because it's a non-surgical. Juniors and residents are easily available in majority of the corporate hospitals, which are very easy for you to work so that your post-operative patients are looked after very well and you just need to go there once or twice in a day, and the rest part is managed by your juniors or the residents. If you land up in difficult situations, majority of the corporate hospitals again will have adequate help from seniors or your colleagues who can help you out in difficult times, particularly during surgery. As I have diverted to joint replacements, but during joint replacement, if I have to by any chance have led to a patellar tendon avulsion, I can ask my arthroscopy colleague to come down and suture the tendon for me, and as well as brace the tendon using a hamstring graft taken from the same incision, which again is an expert in that, where I am not. So this type of an help is easily available in the corporates, whereas in smaller setups, they are difficult to come by. Headache, although it is not to full extent, but in a smaller setup, every part of it is to be dealt by you, whereas in the corporate, you don't have to look after the billing part. Most of the insurance companies will have a tie-up with the insurance with the corporate hospitals. So again, that is not a major issue. And as me and Sidhu were talking the day before yesterday, marketing and establishing the brand is again not your headache. The hospitals will make sure that your brand is established and the hospital marketing will take care of it. With that, I would like to thank all of you for listening and be available for any help you want. You can write down my email ID or the telephone number that I provided. If I can be of any help to you, I surely would like to help you all. Thank you.
Thank you for the educational lecture, sir. If any participants have any questions, they can ask sir directly or they can type in the chat so that we might hear them. There don't seem to be any questions from the participants. I would like to thank sir for taking out his valuable time for us. He has highlighted the need for the high volume of work to get specialized in arthroplasty, as well as to be well versed with the latest techniques and equipment. He also highlighted the fellowships both inland and abroad, which would be preferable for us. He has pointed out in corporate work culture, the latest in corporate work culture, the most important things will be communication and teamwork. And also, the main point I think was in the art of surgery that we need to know what to do if we need to bail out in difficult cases. I'd like to thank sir for this lecture, and we'd like to move on our next session, which is that of academic institutions. For academic institutions, we have with us Dr. Sanjay Dev, who is from D.Y. Patel Medical College. So I would like to introduce Dr. Dev, who is a professor and head of Department of Orthopedics since February 2014. He has completed his MS Ortho from Pune University and has experience of more than 20 years in teaching. He has worked in the Ministry of Health in Oman, as well as worked as a registrar and specialty doctor in the Trauma and Orthopedic Center in UK, in both Manchester, Wales and Morecambe. He has a fellowship in foot and ankle surgery, as well as he is a PG teacher from MS Orthopedics from 2008. He is a PhD guide in MS Orthopedics since 2017 and has recently had 2 students who were awarded with the PG degree. We are indeed lucky to have sir today with us on our panel. I'd hand over the mic to sir and ask him to start his lecture.
Good afternoon, everybody. Am I audible? Hello. Hello.
Yes, sir, you are audible. Sir.
Yes. Yeah. Good afternoon, everyone. Thank you. Thank you. I would like to thank the Mimer Institute for giving me the opportunity to talk on the behalf of the academic institutions and the opportunities or the broader perspective in this particular subject. I would like to share my screen now. Is my screen visible?
Yes, sir, the screen is visible, sir.
Yeah. So today's topic, which is given to me, was academic institutions and the broader outlook, basically for the students who have just passed their MS Orthopedics. And the first step is basically nowadays, as everybody is aware, that after passing your MS Orthopedics, nowadays it is mandatory to do your senior residency. And during the process of this senior residency, what I would suggest everybody is to build up on your academics and curriculum CV. And second is preparing for your further workup so as to become faculty in this particular specialty, because nowadays getting appointed as an assistant professor, you have to successfully complete 1 year of your senior residency, and that requires your research work, and the you may have to face an interview as well, because nowadays getting the senior residency in government institutes is becoming quite difficult. So getting that, you have to face the viva, you have to do your research work, you have to do your thesis work properly, and maintain your CV. So after that, it is a bit easier, as I would say. If you broadly divide working the institutes in Pune, for example, the medical institutes, there are central government institutes and private medical colleges, where you are likely to be shortlisted or you would be considered for doing the senior residency post. As it is a MCI or a National Medical Council directive now, that everybody has to complete their senior residency. So there are government institutes in and around Pune. For example, there are ESIS hospitals, BJ Medical College, YCM, as everybody knows. But getting a senior residency in these institutes is not that easy. So you have to build up on your CV. You have to build up on your thesis work and the papers or poster presentations, whatever you have been doing in the 3 years of your residency program. There are private institutes which are there, and we are quite fortunate if you are in Pune that there are quite a few private institutes where you can do your senior residency. Then I would come to this particular slide where the advantages of being at academic institutes. Broadly, I would say that you get basically a supervised hands-on surgeries, and to develop your skills in the trauma surgery, because trauma is basically the bread and butter in your orthopedic career when you're basically starting immediately after your MS exam. These institutes, which I've just highlighted, these are the institutes where you get quite high volume of cases, and you get quite a good amount of hands-on work while you do your senior residency. The trauma is, as I said, is a bread and butter, and these institutes basically provide you the opportunities to do your basic surgical orthopedic trauma work. So what you need to do is during your senior residency is to remain focused for the goal for which you are working towards getting into your subspecialty sort of field, whichever field firstly, you have to develop that interest in that particular field. And how would you develop the interest? In a broader institute like an academic institute where I am also working, all the broader specialties are there. So you have got almost all the fields which are covered, whether it is spine surgery, minimal invasive surgery in spine, or whether it is trauma surgery, whether it is arthroplasty, arthroscopy, or sports medicine. Almost all these subspecialties are available under one roof, and you are likely to get the exposure during your residency as well as while you are working as a senior resident. So you can develop this particular interest and which field mainly attracts your attention, and that you can easily find out while being in this particular educational institution, academic institution, I would say. So while doing your senior residency, your research is all very, very vital nowadays to remain focused and to remain in the educational institution. Nowadays, particularly the further progression to the assistant professor, or for that matter to the next level, you have to keep on doing research. And research is vital, publishing the paper, oral presentation, poster presentation, where the teamwork is always available to you. So you're not alone. And there are almost everybody in all the units or in all the people who are doing post-graduation, everybody is focused during the course of their residency, as well as the faculties, and you get the help from everybody. And it is a very good breeding ground for you to start your subspecialty interest as well. As everybody knows, the confidence comes with knowledge. So the knowledge which you get and the surgical work which you do is very, very important. And in these all institutes now, you have a skill lab, you have the teaching experience. Along with that, you can develop your leadership opportunities. And very important is undergraduate teaching, where you will develop the art of communication. Because when you need to teach somebody, you have to be better informed yourself. Unless and otherwise you do that thoroughly well, you cannot teach anybody. Leave aside just at the undergraduate level even. And then in all our institutes, we have got postgraduate students as well. So if you are good in both here in undergraduate teaching, where you will develop the habit of talking, where you will develop the habit of delivering the clinic or taking the lecture, these things you can easily develop. And this will give you tremendous confidence in going ahead in your further progression in your career. So why academic institutes? So what I would say is teaching is the best way of learning, as I just said. The audit and self-improvement will come and naturally when you are going through all the cases which are operating in that particular unit or that particular consultant or the unit under which you are working. The self-improvement happens over a period of time. It doesn't happen suddenly. So if you do that, the cases which you have operated or the cases which you have been operated a few months back, and when they come back and you learn through your audit, like which are the complications if they are happening there, or what is the further course of action which you need to take. Then particularly the academic institutes where you get holistic training. The training is given from all these aspects, where your overall personality develops. You will get the as I said, undergraduate teaching, the postgraduate teaching, and then you are working in a team. So where your seniors are there to guide you, where you are having your colleagues with you, and there are postgraduate students working in the same unit. So it becomes a give and take situation all the way. Then cross-fertilization of ideas. This is very important when you're working in academic institutes because the person, if you're working firstly, the orthopedic residency, and you start your career with, you start with firstly is trauma surgery. And that is the bread and butter, as I said already. The trauma surgery will give you the basic tenets or the basic aspects, how to deal with the surgical sort of planning of the procedure. And then you that same planning which you see during your trauma surgery is equally applicable when you go for arthroplasty surgery. The same planning which you can apply when you are doing a minimal invasive surgery. The same planning is applicable when you are doing the arthroscopic surgery. So all these things, they will go hand in hand. And these cross-fertilization of the ideas, like when you're applying even for that matter, something like Elizarov fixator. So you will get the whole idea because you have already gone and seen quite a few cases of fractured tibia and how it behaves. And the same trauma surgery, when it is applicable, when you are doing the same thing in Elizarov surgery, those ideas will come in handy. And that particular crossword idea which are there will give you, they will boost your confidence and will give you the head away while taking up the working the Hello.
You're audible, sir.
Hello.
Yes, sir, you're audible, sir.
My slide is not moving forward. Can I do the stop share and again share it? Because it is not going forward. Yeah, now it is going. Yeah. So next is special advantages going forward. The academic institutes will give you the overall perspective, like in, for example, in arthroplasty, arthroscopy, complicated trauma, spine surgeries under the same roof. So you don't have to go to any other institutes, or for that matter, you can learn the same thing in a very concise way when you're working in academic institutes. Again, organizing the state level meets or conferences, or for that matter, the continuous medical education, CME conferences, is a very common place when you're working in an academic institutes. And that will boost your confidence, that will give you advantage while being there. And it will build up on your CV as well. The career mapping from the bird's eye view, that is also the added advantage. Because you are working in an academic institute already. So whenever your application goes for any particular fellowship, or you're going for any further studies or super specialty work or subspecialty work, that will get highlighted, and your CV will get the basic advantage. Getting the references when you are working in an academic institute is a bit easier. I would not say that it is not possible outside, but it is more carries more weightage because you have already been seen by the other professors, other unit heads, and that gives the basic advantage. So you are getting the references, and going further in your progression becomes a bit easier. What are the further advantages? What I would say is very important is in academic institutes is you grow in your teaching experience. The undergraduate teaching, when you are working as a senior resident, or when you are working even as a JR3 for that matter, that same thing continues, and the teaching experience improves over a period of time. And the further advantage would be the creating and maintaining the respect among your peers and seniors, so that because you are getting exposed to the teamwork and your enthusiasm and your work ethics wise, you will be spotted quite easily, and you will get that in an academic institutes quite easily. The experiences in managing that particular position, whichever you hold in that particular unit, will give you the confidence. The endless opportunities are there. The institutes nowadays, all the academic institutes for that matter, even in a city like Pune, almost all the institutes here are having some of at least one or two international collaborations. and which will give you the added advantage while pursuing your career further. And in a long term, you would never think again while working in an academic institute. So at the end, what I would say is, knowing is not enough, but it should be we should apply, and wishing is not only enough. We must do that. So I thank you again, and thank the institute for giving me the opportunity for giving me this lecture. Thank you very much.
Thank you, sir, for the wonderful talk. If anybody has any questions, they can ask her directly or.
Can you hear me, sir?
Yes.
I'm not aware at the moment whether you are able to hear me or not. So
Yes.
my question to you is that where you are going to draw the line between the SR in your hospital and a third-year trainee in your hospital? If they are competing between the same cases and if they belong to the same unit, who's going to get the preference?
Yeah, basically,
This is a day-to-day situation in many hospitals in India.
Yes, yes. What I would say is basically this is in any hospital, for that matter, in an educational institution, the hierarchy is always maintained. So the senior resident, what cases he can do or what cases he should do, and what cases basically goes for the JR3, that is almost like a drawn line for that matter. So even in that case, that particular unit or that particular hospital or that particular consultant or whosoever is heading that unit, he has to make that. So which are the cases which are basically meant to be up at the level of the JR3? Because we are working in an educational institution, and whatever before you are getting your degree, whatever surgeries you are going to get are basically only supervised surgeries. You are not going to get anything independently because you are not still legally an orthopedic surgeon. Unless and otherwise you have got that degree. Once you get the degree, once you have passed, then you become an orthopedic surgeon. Then once you do that, and then you start working as a senior resident, then you are working not like a resident, but you are a part of the faculty. So once you are a part of faculty, so whichever unit or whichever working pattern which you are following, you have to have a team pattern, team approach. You can't you have to listen to everybody, you have to take everybody along, and then you have to plan the surgical list. So it is not only the question of who is going to do the surgery, but whether that particular surgery is good enough or that particular person is already having that background knowledge and the experience required to deal with that. So all these things will come into play. So it is not only the question at the SR level or JR3 level or lecturer at senior resident level. So you have to deal with that situation as per your routine protocol which you have laid down in that particular hospital or in that particular unit or in that particular department. And you have to work accordingly. That is my frank opinion.
I would like to thank sir for the informative talk. He has indeed highlighted the special advantages of academics in going forward in our career. It highlights the need for building up our CV as well as the need for presenting more and more papers and presentations in conferences. And the most important point was that the love of teaching should have a place in our hearts. I would like to thank sir for giving this informative talk. We would like to move on to our next session. Our next session will be about government medical services. For that, we have with us Dr. Mahendra Garad from Aun Civil Hospital. He completed his MS Orthopedics from JJ Hospital, Mumbai, and is presently working as a consultant orthopedic and knee surgeon at the district hospital in Pune. He has a special interest in knee scopy and arthroplasty. I'd like to invite sir to continue his talk and hand over the mic to him.
Hello.
Yes, sir, you're audible, sir.
Okay. Can I start?
Yes, sir, you can. Please start.
Okay. Can I share my screen?
Yes, sir, you can share your screen.
Okay, possible, I will share. Is it visible?
Yes, sir, the screen is visible.
Okay. Good afternoon, everybody. I am asked to talk on what are the opportunities to the orthopedic surgeon in a government health system. So I am more concerned with the Maharashtra health government system. I will give the brief idea about what are the opportunities in the government health system for an orthopedic surgeon. Yes. So there are three types of government hospitals. One are the medical college and teaching institute attached to the hospitals. These are the public health hospitals run by the state government, and other one is district hospitals, which are connected as a public health sector. These are run by the director of health services, and third one is the corporate hospitals. Which are the corporation hospitals? These are the run by the big metropolitan cities. These are the some hospitals and teaching institute which are run by the big corporations like Bombay Municipal Corporation, Pune Municipal Corporation, or Thane Municipal Corporation. So there are the three types of government systems in that is the medical college, public health hospitals, and corporation hospitals that is run by the metro cities, metro corporation hospitals. We'll see what are the opportunities in the medical college and hospitals. Medical college and hospitals, there is a good opportunity for the orthopedic surgeons, as these are the tertiary hospitals located in mostly metro cities. There is a good infrastructure for the orthopedic surgeon as a big OT complex. OTs are the modular OTs, other infrastructure like supporting staff, technical supports, and colleagues. There are a lot of opportunities for the orthopedic surgeon in a medical college. And how we can get the opportunity to work in a medical college? There are some posts which are permanent and some posts are on ad hoc basis. So we can join permanently or on ad hoc basis, or there are the good salaries also. So, and the one basic advantage of this joining the medical college is we have opportunity to grow our knowledge with our colleagues and teaching institutes. And the other disadvantage of this is that is the job is transferable. So if you enter in the medical college as assistant lecturer or professor or associate professor, your job is transferable to any medical college. So you are coming in a transferable job. But big advantage of this opportunity is these are in metro cities. You can live in a metro cities and very good opportunity to improve your skill and knowledge. Other are the corporation hospitals like KM Hospital, Sion Hospital, Nair Hospital, Cooper Hospital. that is the Rajiv Gandhi Medical College. These all are run by the corporation. That is the Mumbai Corporation or Thane Corporations. The advantage of these corporation hospitals are these hospitals are located in a metro cities, have a good infrastructure, like you can get a very good infrastructure in a hospitals. So you can do the all type of your interest surgeries, and you can have a technical supports available also. But these hospitals are run by the local body. The control on this hospital is local body control, that is corporates and corporate municipal corporations. Salary wise, it's a very good salaries are there. And the big advantage of working in a corporation hospital is that your job is transferable only in that city, only in that corporation area only. So in state government medical college and hospitals, your job is can be transferred from one city to other city, like from Mumbai to Pune, Pune to Aurangabad, Aurangabad to Nagpur. So in the medical college, state government medical college, you have to change the city. But in corporation hospitals, your job is transferable only in the corporation hospitals only. So the big advantage is that you live in only one city. And other are the public hospitals run by the state government. There are two types of public hospitals run by the government where orthopedic surgeon is posted. One is district hospitals and other one is trauma centers. Now government has started new trauma centers, especially for the trauma patients. So there is a team of surgeon, orthopedic surgeon, anesthetists, and other supporting staffs. So these trauma center hospitals and district hospitals are run by the state government. Seeing that what are the opportunities in the district hospital? Your district hospitals mostly are having a good infrastructure, but like medical college, you are the deciding person. So you are the boss. So you have to decide what you have to do, what you are not to do. Most of the district hospital nowadays are converting in a teaching institute. What courses are the teaching courses started here? The CPS and DNB courses are started at every district hospital. So like medical college, district hospitals are now becoming as a teaching institute for CPS and DNB. So helping hands are more available nowadays at a district hospital. As in Pune, there are 4 seats of CPS and now DNB is starting. So 8 residents and 3 to 4 consultants are there. So nowadays district hospitals are equally teaching institute like a medical colleges. Other problems previously at district hospitals was mainly of the getting the implants and other surgical materials. But nowadays the district hospitals are all covered under the Ayushman Bharat or Pradhan Mantri Arogya Yojana. And in state government, similar insurance Yojana is Mahatma Phule Arogya Yojana. So all publics are covered under these 2 schemes. So there is nowadays no problem of getting implants or materials. So for any surgery, at district hospital nowadays we can perform all type of surgery. That is even including the joint replacement, spine surgeries or scopies, all scopies and all trauma we can do under these schemes. So as the district hospitals are nowadays becoming as equal to a medical college. And here other thing, the advantage of district hospital compared to medical colleges is here you can decide what you want to do. So you are the key person. So But the other disadvantage of district hospital is your job is transferable. So you can transfer from one hospital to other hospital, like in a district or in other district all over Maharashtra. So the disadvantage is that you cannot be in a one city, or your job is transferable. But there is a good opportunity nowadays in district hospital to work or to start work. And other government setup for orthopedic surgeon is trauma centers. These all trauma centers are situated mostly at taluka places. Some are at district levels, but mostly are at taluka places. But now trauma centers are new ideas. They are in developing phase. So some trauma centers are developed, but other trauma centers are in developing phase. There is nowadays the infrastructure is very poor for orthopedic surgeon. There is in trauma center there are no technical supports or technical or skilled staff or skilled workers or technicians are not there. So you have to do limited surgery as per your skill and as per your support. So nowadays trauma center there is not much to do, but district hospitals and government medical colleges are very big opportunity for the orthopedic surgeon, as covered under all schemes, and we are getting all materials and implants for the orthopedic surgeons. It's over. If any questions, can ask. Hello? Hello? Hello?
Thank you, sir, for the informative talk. It was certainly a difficult topic to talk about government health services. You have indeed highlighted the allotment and sharing of responsibility between corporations and that of the state government.
Yes.
One of the main disadvantages of the government job remains that it is a transferable job. But like he highlighted, in district hospitals, we get to be the ultimate authority and decision maker for all types of surgeries.
Yes.
We are thankful to sir for taking out his valuable time and delivering this lecture. I would like to move on to our next session, which will be the setting up of a corporate hospital. For this session, we have with us our own faculty, Dr. Yash Shah. I'd like to introduce him. Dr. Yash Shah is working as an assistant professor in Miras Medical College for 1 year. Afterwards, he continued for 4 years as assistant professor in Mimar Medical. And he has been working as 4 years as chief orthopedic consultant in Matruseva Medical Hospital, Pune. He has done numerous fellowships in sports rehabilitation, like the Johnson Fellowship, as well as the fellowship in arthroscopy under Dr. Abhay Narvekar. Also, the Smith and Nephew observership with Dr. IPS Oberoi at Artemis Hospital, and was the official doctor for the Cricket World Cup in 2011 and the IPL in 2011 and 2012. I would like to hand over the mic to sir and ask him to continue with the further lecture.
Yeah, good afternoon, everybody. So my topic is setting up your own nursing home or your own hospital. So I'll just share my screen. Yeah, so is my screen visible? Full screen. Yeah. Yes. So the target audience for this talk is basically young budding orthopedic surgeons, and many of you are from a variety of areas. Some of you are from metropolitan cities, some of you are from remote of villages. Now the thing is, everyone to set up your own hospital, to have your own name, very not practical. Sometimes there are lots of obstacles, mainly financial obstacles, or you don't get a good place. Or if you're living in a crowded metropolitan city, so there are better job prospects in a corporate hospital than your own hospital. So I'm going to just share with you my views about setting your own hospital. There are pros, there are cons, And I myself have made mistakes in setting up the things. So Adolf Hitler once said that if you learn from your own mistakes, it is you are great. But if you learn from other people's mistakes, you're greater. So you can learn from my mistakes. I'll just guide you through the process. Now, I have my own hospital in the heart of Pune, and that is basically you should, whenever you plan your own hospital, you should have your own view, your own vision. So starting with location, if you are planning to be a trauma center, keep it on a highway, get the plot accordingly. Don't keep it near crowded areas, or don't keep it near noisy areas where your patients are going to get disturbed. So that planning has to be right from the beginning. So your basic plan, you should have a vision. Now you can either build a huge hospital, maybe 7 floors, maybe 10 floors, 500 bedded. That vision should be there right from day one. You can't just start a small shed and then later on build it into a multiple hospital. You have to have that vision on day one. And if you have a vision of starting a medium hospital because of your financial constraints, what you can do is you start building the ground floor. Then as you get finances, keep building the first floor, the second floor, keep building up. But your basic plan should be ready and your goal should be ready, that in 5 years I'm going to expand this much, and in 10 years I'm going to do this much. Okay, so coming to the building part of it, I'll just go through each heading. So now you have to by law provide a parking area. So now every 4 beds need at least 1 car parking area or 2 scooter parking areas. So according to your, suppose you have a 500 bed hospital, so you should have the plan ahead. On the ground floor, you should have an entrance, have a reception, you should have a billing department. Maybe your radiology can be on the ground floor. Your consulting rooms may or may not be on the ground floor. That is not compulsory, but your casualty has to be on the ground floor. And preferably the casualty needs a separate entry so that your ambulances can come in and out and without hampering the OPD complex. So if you have the space, if you have the money, do plan it that way. Of course, now you can have problems, you don't have space. So that is okay. Then your casualty becomes your consulting room, and even then that also becomes your OPD and your waiting room and everything. So according to that, but things like pathology, things like your HR department, your billing, your medical records, that can go in the basement. But the only problem of keeping a basement is like you must have seen when Chennai got flooded. So a lot of medical equipment got spoiled, a lot of medical records were lost. So this is also important. That is why I always keep a electronic copy of my hospital records. But the problem is that even if you keep only electronic records, the government authorities, they come to your hospital and they want a paper backup. I don't know why, but they are old school and they want a paper backup of each of your records. So if you have an electronic record of all your hospitals, very good, but you must keep a paper backup as well. So that's double work, in fact. And you should always have a free space around your building so that a fire engine can fit in that. So that is nowadays a norm. Old hospitals don't have that, but newer hospitals have to get a free space around it. And staircases should be 5 foot wide and at least 2, so that in case of a fire, you should be able to take out the stretcher and the patient should be carried out. Always, you should plan for 2 lifts. One lift may fail, so you should always have a backup of another lift. And ambulance should have a separate parking. Normal patient parking should not interfere with the ambulance parking, and ambulance should be able to get out and in very quickly. Also, if you are doing a big hospital, as per the fire safety norms, you are supposed to have 2 underground tanks. 1 tank, 1 tube, and that also has to be a pipe connection. You have to have extinguishers on each floor. So you'll have to go to a professional and he'll set up the hospital. You can't do everything on your own. And whenever you build a hospital, you should plan for expansion. So conference room in future, you should have some staff quarters or RMO room so that your resident doctor can stay there. So have that vision and plan ahead. So your waiting room also, you should have a proper reception where patients can approach, take an OPD case paper. There should always be one counselor. Now this is something which is not possible in a small hospital, but a counselor is, suppose you tell a patient that you need a TKR. So you are not going to sit and explain in detail about 1 hour session, what is TKR, why you need it. So you should have someone to help you out. But in such a busy practice, you need someone like this. A billing department should be separate. as far as possible, the doctor himself should not ask for money. That avoids fights and that avoids a lot of bad name. And keep a software as possible, if possible, for your OPD setup. And like I said, paper backup is very important. Now, your OPD setup should have minimal furniture. And when you examine female patients, you should have a screen. You should have a female attendant, and a basin is needed so you can wash your hands. You should keep basic things like a dustbin, a hammer, a torch, a goniometer, and a cupboard if you want to administer any syringes or anything. So some storage space should be there. Good lighting, good ventilation, these are hallmarks of a good OPD. Keep bed sheets changed, because many a times, and especially after this COVID pandemic, patients are very fussy. They are fussy about sleeping on the same examination table. So one good thing I've seen in one of the corporate hospitals I've worked in, they have a paper sheet. And once the patient sleeps on that, they immediately tear up the sheet in a dustbin. Of course, that wastes a lot of paper, but some fussy patients do demand it. And view board is important to see X-ray and MRI as well. So a big view board, not a small view board, and have a printer ready. So sometimes a patient asks for printouts of your prescription, because once you grow into a busy practice, you can't sit writing the drug names. You should have a software, so that printer is very important. Now, pharmacy is also one of the important things in a hospital. But by law, you need a qualified pharmacist. He should have either D-Pharm or B-Pharm degree. And you will have to register your pharmacy with the FDA. You'll also have to register it to GST. The thing is, you can either keep a partnership with the pharmacist or you can employ him. So that depends on how you want to run the business. But if you have a partnership, then a lot of headaches. You have to go through a lot of documents and billing, and that increases your headaches. So sometimes you can just outsource it and let him run it. Nowadays, patients are very fussy. Earlier, patients would sleep even on a mattress, even like if the beds were full. But nowadays, people want 5-star treatment. They want the best of beds. They want a good private room. They want attached bathroom. So you have to plan for all this. And you can keep a Fowler bed. Okay, so Fowler bed, patient can at least eat comfortably. Traction kit has to be there in the ward. And sometimes you need to give leg elevation, so bed blocks should be there. The bed should be well spaced. No keeping tuberculosis patient next to an arthroplasty patient. There's no sense in that. So have a good planning. Keep male wards, female wards separate. If preferable, keep an ortho ward separate. And your dressing drum should be in all the wards for any dressing. Keep a piped oxygen if possible. Just rather. Emergency drugs should be at all the wards, on all the floors. And each bed should have a bell to call the nurse. Your is not compulsory, although patients demand it, but you should have windows and well-ventilated wards. And fire exit should be well labeled. So this is my ward. You can see that the beds should be at least decimal spaced, no crowding. Now, most important as surgeons, we are always worried about how to set up the OT. So, very big controversial topic, is laminar needed or not? My belief is that laminar is a good thing. It is needed. Now, even in this, there is a vertical laminar floor and a horizontal laminar floor. So please do not install a horizontal laminar floor. That is not scientific. A vertical laminar floor is important. And many of these people who build laminar airflows for you, they will tell we'll do a modular OT as well. So they'll promote you for a stainless steel wall. So although all that is expensive, it is not compulsory. I mean, I have worked in corporate hospitals which have tiles and they are doing well without infection as well. So don't go for stainless steel walls. Don't waste your money in this. And there is something about the flooring. You can either put epoxy flooring or vinyl flooring. So the problem with vinyl flooring is that after a few years, you get air bubbles under the carpet. And that is not a good thing. So, but the problem with epoxy is that it gets scratched with sharp instruments. So you have to choose among them. As far as my view is concerned, you can even put tiles, but you should maintain your aseptic field. And scrub area should never be inside the OT. That is all old-fashioned. Your scrub complex should be outside the OT. You should have a doctor's room where other doctors can relax, and never allow food inside the OT complex. Even your autoclave room should be in the OT complex if possible. Then there should be a window, a sterile window where you can pass sterile instruments. And there is a horizontal autoclave and a vertical autoclave. So if you have the budget, go in for a horizontal autoclave because that is a better sterilization method. Vertical autoclave keeps it moist. And keep 2 set of chappals. One chappal or OT shoes should be outside in the OT complex and one outside your main OT. So that's double sterility. Now this is my OT. So if you look, there are OT table is of 2 types. Either you put a foot operated OT table, so that works even when the light is there's no power, or you can have a button operated electro-hydraulic. So according to your preference, you can choose, but better to have a dual power supply. So in case there is a battery failure or some electronic component failure, you can operate it by foot. And always keep well-ventilated windows so that if a power failure goes off, you can get natural sunlight into your OT. Now, if you look at this, I have kept electric power outlets on each wall. So that makes life very simple. So if I want to operate the head end this side, head end that side, I can always modify it as per my wish. Now, this is the equipment trolley which I was talking about, so that all your equipment can fit on each shelf. Now, the mistake I made is I kept a cupboard with all instruments. So that should not be kept. Your furniture should be more modular. Now, equipment also, you'll have to invest in a few things. Plaster cutter, keep a backup, because if your plaster cutter fails, you'll have at least a saw to do it. You should invest in an X-ray shooter, X-ray table. Now, digital radiograph is not compulsory. You can even have a computer radiograph. And if you're short of budgets, you can even have the old dipping method. But physiotherapy, you can invest in a traction table, a drill machine, and other special equipment if you want to specialize in some other field. So this is my setup. The important thing is that you should have a chest stand, so that if you want to take a standing X-ray, that chest stand is important. Now, the X-ray printers, some of them need AC, some of them don't need. So you should have preferably a printer which does not need AC. Instruments, you should have all the general surgery instruments. You should have lots of armamentarium ortho instruments as well. Keep them properly so that organized you can find out where what is. And you have to maintain your hospital as well. So sometimes you have to bear the brunt, do the wiring, plumbing, repair your instruments, whatever. See the tone drapes and manage oxygen cylinders, even small things. Okay. Staff also you have to maintain. And main thing is you have to keep your staff happy. So keep... sometimes you have to register with the ESIS, you have to register with the TDS, and if your trained staff is absent, then sometimes you have to postpone your case. That is the drawback of your own hospital. Now you have to register with local laws like fire department, the pollution control board, radiation board, FDA, GST, local corporations, a lot of lists. And sometimes society doesn't give you NOC. Sometimes you don't have your permission to set it up in a residential building. So to sum up, what are the challenges, what I face in setting up your own hospital? Sometimes the patients wake you up at night for something very trivial like itching. Then you have to get up. Sometimes the patient has some violence issues. They break things at your hospital. You have to repair even basic things. If you're going for cashless, then sometimes the insurance companies don't pay you on time, or in government schemes, your payment is delayed. And you can't take a holiday really. Because if you go away for say 15 days, then your whole practice suffers. If you're stuck in a surgery, you'll have to call someone special to help you out. You can't do any hi-fi surgeries which require crores of investment like robotic, laser, spine. And sometimes you have to manage simple things like a light bulb broken, staff attendance, quarrels. So I would like to end my talk with this saying from Marathi. There's a saying, Swami Tini Jagansa Ai Vina Bikari. So if you have your own hospital, I would say it is Swami Tini Jagansa Ayan Vina Bikari. You respect your staff, they will respect your patients, and you will get a good practice. Thank you. So if there are any questions from any one of you, I would like to answer.
Not questions, but I think you missed one point.
Talk on.
Question. It's not a question, but I think you just missed on a point that you need round-the-clock medical officer in the premises.
Right.
Serve the patients.
Definitely. And if you yourself are not planning to sit there, then you have to at least employ maybe an MBBS person. If you can't afford an MBBS person, at least an Ayush person, but do not give him any responsibilities like administering drugs or something, because that's a legal issue. But definitely you need a face, you need someone to be there 24 hours. It's a full-time thing. You just can't leave it and run away. And there is a question in the chat section. How many years of prior experience you would suggest before setting your own setup? Now, the answer is at least until you are confident of performing all the basic surgeries perfectly. So maybe 3 to 4 years, at least 3 to 4 years post MS. Then you can think of starting your own setup. By the time you would get some funds also, and start small, but keep scope for expansion. That's my belief. Any other questions? Yes, so I think there are no other questions. So we had a good session today. It was a very good academic feast and very helpful tips from Dr. Panchwag about the oncology, Dr. Agashe about arthroplasty, and we had a good information about from Dr. Sanjay Dev also and Dr. Garad also. I hope we've inspired you somewhere or the other, and hope to see you soon on our session 4 on Sunday at 2 o'clock. So do join in at that time as well. Thank you.